Good evening, all. A warm welcome from behalf of Team MAHAIP 2026 on the 10th episode of Friday Ka Punch MAHAIP Ke Sang. So here I welcome each and every delegate, all the expert, Dr. Pankaj Bhansali sir, Dr. Prachiti Kadam ma'am, and all the speakers which are from the 5 different regions of Maharashtra. And today's theme is pediatric nephrology in office practice. So now I request respected Dr. Sanjay Pakmode sir for the welcome address. Over to you, Sanjay sir.
Thank you, Sachin. Namaskar. Welcome to the MAHAIP platform. Now, this Friday Ka Punch MAHAIP Ka Sang is a very beautiful program where the people from all the regions of Maharashtra, that is the 5 regions of the Maharashtra, they are the representative and they present. So means they are supposed to present so many topics which are very common in routine day-to-day practice, and we get a lot of inputs from them. At the same time, the comments made by the experts will also give means some inputs in our practice, and it helps in updating our practice and rather helping our patients in a better or rational way. So first of all, let me welcome you on the MAHAIP platform, our treasurer Dr. Ravindra Sonone, then our EB ma'am from Marathwada region, Dr. Sucheta Pofre madam, as well as madam is MOC today, and then our EB from Vidarbha, Dr. Sachin Patil, and scientific convener, Dr. Minha Sheikh sir, and all the uh, MAHAIP people, our office bearers who have joined, our CIP office bearer who have joined for the today's Friday Ka Punch. And I also welcome the presenters, Dr. Snehal Nagre from Hingoli, then Dr. Amol Madve from Thane, then Dr. Pawan Devre from Nasik, Dr. Shishir Murugunde from Kolhapur. Sir, I had already come on so many times on the MAHAIP platform. Once again, I welcome you, sir. Dr. Ashwin Meshram from my own city, Nagpur. And at the same time, the today's experts, Dr. Pratichi Kadam Pillai madam from Mumbai and Dr. Pankaj Bhansali from Chhatrapati Sambhajinagar. So without wasting time, I hand over to Sachin and Sucheta ma'am for further proceedings.
Thank you sir for your blessings for today's program. Now I request our treasurer Dr. Ravindra Sonone sir for the welcome address. Sonone
Yes,
sir, over to
thank you,
you.
Sachin. Yes, yes, thank you, Sachin. Good evening, all. I welcome respected President, sir, Dr. Sanjay Pakmuri, sir, our scientific convener, my teacher, Dr. Minaj Sheikh, sir, then moderator, Dr. Sachin Patil and Dr. Suchita Fople, madam, and all the speakers. So I am Dr. Ravindra Sonone, Treasurer of MAHAIP. It is my pleasure to welcome you all to the 10th episode of our academic series, Friday Ka Punch. Now, this platform was created with simple vision to bring powerful, practical, and office-based pediatric learning right to your screens every Friday night with the punch. So today's theme is pediatric nephrology in office practice. So just for example, spontaneous bacterial peritonitis, it is a critical but often under-recognized complication. Second, hypertension, that is one of the most important OPD emergencies. Then this postnatal evaluation of fetal hydronephrosis, a topic with increasing relevance due to improved antenatal scans. Now, for management of nocturnal uresis, a very sensitive issue for parents and children. And medicine and renal injury, a topic every clinician must know, especially with rising use of multiple drugs. So these themes are not just academic, they impact every pediatrician's daily practices and also improve patient outcome when understood well. I will also like to acknowledge our experts for the day, Dr. Pratichi Kadam Pille and Dr. Pankaj Bhansali sir, for guiding this today's scientific session. And special thanks to our moderators, Sachin Patil and Dr. Suchita Pople, madam, and all speakers, Ashwin Meshram sir, Shishir Murgunde, our Dr. Pawan Devre from Nasik, then Dr. Amol Madave and Dr. Snehal Nagre. And so, on the behalf of Team MAHAIP 2025, I welcome again all you and let us learn, share, and grow together. Thank you, Sachin.
Thank you, Ravindra sir. Now I request Dr. Sanjay uh, Deshmukh sir. Sir is there. I think our convener. Okay. So for further proceeding, I request my co-moderator, Dr. Ma'am, Dr. Suchena ma'am, please
Yes, yes. Am
go
I
ahead.
audible? Dr. Sachin, am I audible?
Yes,
Yes,
ma'am.
yes,
Yes, ma'am.
yes.
Yes, ma'am. Yes, ma'am.
Thank you. And we have come to the fag end of this year. But still, it's really heartening that we are continuing with the same zeal. So the pediatricians are glued to the screen for every Friday punch also. And I congratulate Dr. Minhas sir, who has carved this all the things so neatly. And Dr. Minhas sir, will you please address the gathering here? Dr. Minhas sir.
Thank you. Yes, madam. Thank you, madam. Good evening, President sir, our dear friend Ravindra Sonavne, and all my friends. It's been pleasure to be all around, especially people from our own state and city and all. So we'll go ahead straight to the proceedings for the happy learning. Best wishes for one and all. Please, over to you, madam.
Thank you, Minhas sir. Thank you, Minasa. And we have our experts today, Dr. Pankaj Bhansali from Chhatrapati Sambhajinagar. He's the only nephrologist in Marathwada region. Am I right, Pankaj? Pankaj, unmute. Please unmute yourself. So he's
Yeah,
at
yes,
CS.
ma'am.
Yes, he's at a CSN Star Hospital at Aurangabad, Chhatrapati Sambhajinagar, as well as associate professor at IMSR Medical College, and had 4 publications to his credit, and he's has written a chapters in pediatric nephrology book. He was EB member of ISPN. And another guest, our expert is Dr. Prachiti Kadam. She is a fellow of pediatric nephrology from University of British Columbia, Vancouver, Canada, and a consultant at Surya Hospital and R.N. Cooper Hospital, Mumbai. She has multiple publications to her credit. And one award I didn't recognize Prachiti, Travel and Award for Platform Presentation at Western Medical Conference, California. I didn't get it. What is that?
It was a research award which I got in the state of California. It was a study I had published, which got a award for presentation, and
Okay.
that is So that is what it was. It was a travel
I
award.
thought you are in travel also.
Yes, yeah, that is very important.
Yeah. And our esteemed speakers of different regions of Maharashtra are Dr. Snehal Nagre from our own Hingoli, Marathwada, and he's a renowned pediatrician. Dr. Amal Madve, a pediatric nephrologist from Jupiter Hospital, Thane. Dr. Pavan Devre, also pediatric nephrologist from Nashik. Dr. Shishir Murugunde from Kolhapur, and Dr. Ashwin Meshram from Nagpur. So let's move ahead to our scientific program. Dr. Sachin,
Yes.
will you please take over?
Yeah. So I request now our first speaker, Dr. Snehal Nagre sir, for the talk spontaneous bacterial peritonitis.
Yes.
Over to you, sir.
Yes, yes. Okay.
Yes, sir. PPT is visible.
Yes, PPT is visible.
Yes, sir. Kindly start. Thank you.
Good evening to all respected seniors and friends. As the opening batsman of Friday Ka Punch, I am presenting spontaneous bacterial peritonitis in nephrotic syndrome. Spontaneous bacterial peritonitis is defined as development of bacterial infection in the peritoneum despite absence of an obvious source for the infection. Acute abdominal pain in nephrotic syndrome is a well-known, well-recognized clinical symptoms primarily related to peritonitis. The other causes of acute abdominal pain in nephrotic syndrome are intussusception, ischemic colitis, splenic infarction, and renal infarctions. Uh,
Primary peritonitis is well-defined infectious complications of nephrotic syndrome. It usually occurs in the first 2 years of diagnosis, especially during relapse period. Its incidence being 1.5 to 3.7% of the children with nephrotic syndrome and mortality rate of 9%. In patients with known case of nephrotic syndrome with relapse, there is increased susceptibility to bacterial infections. The most frequent type of infection is spontaneous bacterial peritonitis, and others are sepsis, cellulitis, pneumonia, and urinary tract infections. Now, what are the immunological abnormalities that leads to increased susceptibility to infections? This includes decreased serum immunoglobulin levels due to urinary loss, impaired antibody generation, defective opsonization due to decreased level of complement factor B, and abnormalities of cell-mediated immunity. The other proposed explanation includes edema fluid acting as a good cultural medium, protein deficiency, decreased bacterial activity of leukocytes, immunosuppressive therapy as a part of treatment of nephrotic syndrome, and splenic hypoperfusion due to hypovolemia. Now, we will see the clinical manifestations. It includes fever, which is most of the times associated with chills. But fever is often masked by corticosteroid therapy. The other signs includes nausea and vomiting, abdominal pain and tenderness, worsening ascites, and altered mental status. You must remember that approximately 13% of the patients present with no signs or symptoms. Now we will see the peritoneal signs. The acute abdominal pain with tenderness, guarding, and rigidity. The rigidity which is exacerbated by the moving of the peritoneum. That is with the cuffing, with flexing the hips, or eliciting the Bloomberg sign, meaning that pressing a hand on the abdomen elicit less pain than releasing the hand abruptly, which will aggravate the pain as peritoneum snaps back into the place. Rigidity is highly specific for the diagnosis of peritonitis, the specificity is being 76 to 100%. Red umbilicus sign. If it is present, it is erythema around the umbilicus is a clue for early diagnosis of spontaneous bacterial peritonitis and results from an inflammatory process that spreads to the subcutaneous facial plane and infiltrates umbilical skin. Now, positive organisms. The most common pathogen in primary peritonitis is, in the past, it is used to be Streptococcus pneumoniae, but its incidence is declining due to increasing use of antibiotics and, of course, pneumococcal vaccination. The other causative organisms that are gram-positive, they are group A streptococci, enterococci, and staphylococci. Gram-negative organisms such as E. coli, Enterobacter, Klebsiella, and Acinetobacter accounts for the 50% of the patients. The anaerobic infections are not common as the oxygen content, the ascitic fluid is quite high. A spontaneous fungal infection can often follow a spontaneous bacterial infection that has been treated with antibiotics. The spontaneous fungal peritonitis most commonly caused by Candida albicans. Now, the diagnostic workup. We must do total leukocyte count, differential counts, total proteins, albumin globulin ratio, serum protein, C-reactive protein, and procalcitonin. Paracentesis, that is needle aspiration of ascitic fluid, must be done. At least 20 ml of the ascitic fluid should be inoculated in aerobic and anaerobic culture bottles for the better isolation. If you are collecting in a sterile container, the positivity is 40% as compared to around 80 to 90% with culture medium. The spontaneous bacterial peritonitis is diagnosed if fluid contains neutrophils more than 250 cell per cubic millimeter and exudative fluid. Now, lastly, antimicrobial therapy. In nephrotic syndrome associated with primary peritonitis, where pneumococcus is likely offender, the ceftriaxone is the drug of choice. As drug resistant to pneumococcus in non-meningeal infections in India is infrequent. So the routine addition of vancomycin is not recommended. In gram-negative peritonitis, ceftriaxone or cefotaxime with beta-lactam and beta-lactam inhibitors like combination such as piperacillin and tazobactam, cefoperazone and sulbactam, or carbapenems should be used. Aminoglycoside should be avoided if possible due to risk of precipitating hepatorenal syndrome. Now, the antibiotic therapy is sufficient for 5 days in patients with quick response and uncomplicated course. Antibiotic therapy may be longer in those with delayed response and, of course, with bacteremia. Procalcitonin level may be used to guide the duration of antibiotic therapy. Thanks. Thank you.
Thanks. Thank you, Snehal sir. It's a really crisp and concise presentation. Now I request Dr. Pankaj sir for your expert comments. Pankaj sir, anything you want to add?
Yes, sir. Yes, am I audible?
Yes, sir.
Yeah. Okay. So, very good presentation, Snehal sir. Short, crisp, and with very clear message. Few things. Whenever we are in nephrotic syndrome, we used to say what can kill the patient are infection, not the disease per se. And if we see the mortality, they are more common with infections and maybe thromboembolic complications. So that's why it's very important to pick them up early, start immediate management. Now, whenever we are treating infection, be sure to add stress dose of steroid, particularly if child has received steroid in last few days, because otherwise the normal expected stress reaction may be suppressed because of suppression of hypothalamic pituitary axis. And many of them, if present late, they may straight away land up with sepsis. So in this case, even a single day will matter. So whenever we suspect any infection, may it be from simple like cellulitis to SBP, spontaneous peritonitis, treatment needs to be aggressive with all cultured scent, start antibiotic immediately. Now, generally when child present in sepsis or hypotension, we all know that we use crystalloid as a first line of therapy whenever child has hypotension. Yes, when if it is not available, crystalloid do remain a first option. But in these scenarios, when there is a significant low albumin level, we can consider albumin a slightly on higher side, particularly if child has sepsis with significant low albumin, particularly less than 1.5. So provided creatinine is normal and child has urine output. So maybe we can shift colloid a slightly on higher side whenever we are treating nephrotic with sepsis. And another common antibiotic which we see getting prescribed is metronidazole. We all shall remember this is spontaneous peritonitis, so there is no role of anaerobic cover. So no point of adding anaerobic cover like metronidazole for treating this peritonitis. Yeah, Pratichi, anything
Thank you,
you
sir.
want to add?
Yeah, really good take-home message. Hit hard. That's the best thing. So,
Yes.
Dr. Prachiti ma'am, do you want to add anything else?
Yes, so nowadays, with the advent of unfortunate WhatsApp consultation and phone consultations, and if a nephrotic has approached either your clinic phone or OPD phone or your personal phone with abdominal pain, it's absolutely vital that this child is sent somewhere close to home for just palpation of the abdomen. Because invariably what happens is early peritonitis gets missed because probably they may be prescribed some proton pump inhibitor or some consider it to be gastritis due to steroids, and this basic test of looking at rebound tenderness is missed. So any child with abdominal pain in a child with nephrotic syndrome has to be palpated. Even it is late, even it's early in the morning, needs to go to the nearest casualty and needs to be palpated. And presence of tenderness, presence of rebound tenderness in a child of nephrotic syndrome always turns out to be peritonitis. The second thing is ascitic tapping is absolutely essential for diagnosis of the pus cells or the neutrophils in the peritoneal fluid. But in certain scenarios when the amount of fluid is minimal or not tense ascites, and still the child has uh, signs suggestive of peritonitis, and you want to do a USG guided tapping, which probably will come the next day, you'll get the USG access. I would always say clinical diagnosis of peritonitis is absolutely essential and it is life saving. So yes, we must do a ascitic tap, but in case it's not possible at your at your place of practice, or you are awaiting a USG guidance because the abdomen is not tense, clinical diagnosis and the first dose of antibiotics is absolutely essential and life saving. And yes, once you have access to ascitic tap, because we need it for the culture and to isolate the organism, so it's very, very important. But clinical diagnosis of peritonitis is very, very essential, so that sometimes gets missed, so that is very important, I think.
And
Thank you, ma'am.
another practice
Yes,
is
yes, sir.
so a lot of the time we see patient getting prescribed sonography. For what purpose, I really don't know. For finding fluid, clinical examination is sufficient. To confirm tenderness, we don't need USG probe.
Absolutely.
Our hand is sufficient. So practically, sonography does not aid anything further in the diagnosis of nephrotic, neither in the diagnosis of peritonitis. So let us not waste time and money on USG.
Though the time is of AI, most important is clinical examination, which we taught since our UG days. So now going to next topics, I request Dr. Amol Madve to please start your.
Is my presentation visible? Can somebody?
Yes, Amol, it's visible.
Yes. So good evening, everyone. Yes. So we will be discussing hypertension in infection-related glomerulonephritis. Very interesting topic to discuss. I think since undergraduate days, we have been taught that after nephrotic syndrome, the next important question that will be asked in the exam is acute glomerulonephritis. The classic presentation which AGN presents is a periorbital puffiness with a cola-colored or a black tea-colored urine and a hypertension that we pick up on examination. Now, over the period of times, there have been a lot of overlapping terms which could confuse us in an acute setting when the child has acutely come to us, like a post-streptococcal GN, or is it a nephritic origin of nephrotic syndrome, or is it synpharyngitic GN like a IgA nephropathy, or a nephrotic syndrome has come with hypertension. But there is no urgency to pinpoint so long as we can manage the acute problem that we are facing. So it is very important to understand the subtle and the obvious similarities and differences of infection-related GN, which we'll be calling as IRGN subsequently, with our classical post-streptococcal glomerulonephritis. So let's look at this 9-year-old boy who presented with 3 weeks after sore throat with a periorbital puffiness, a cola-colored urine, a blood pressure of 118/92. He had gained about 3 kgs weight. His urine showed 3 plus blood, 2 plus protein, creat was 0.9. ASO titer was raised and the C3 values were low. So prima facie looking at him, he looks like classic post-streptococcal glomerulonephritis because one, there was latency of some time between his infection and the glomerulonephritis. He is relatively stable. He just needs control of edema and hypertension, and hopefully the C3 becomes normal after 6 to 8 weeks. Now, what happens in infection-related gene? How is it different? So the first thing to notice is the glomerulonephritis presentation in IRGN is during an active infection. So there is no latent period between infection and the glomerulonephritis presentation. Usually, as opposed to streptococcus in PSGN, usually it is staphylococcus and other gram-negative organisms that cause IRGN. C3 levels are classically low in PSGN. They may or may not be low in all patients of IRGN. Yes, antibiotics are extremely essential in IRGN. And if at all this child gets referred to a nephrologist, it may show IgA dominant deposits. Now, once we have understood to differentiate these two things, let us see what happens with another boy, same age, 9-year-old, periorbital puffiness, cola-colored urine, hypertension, weight gain, similar profile of labs, but you notice that he has redness over abdominal wall, which is tender. Just like what Snehal sir said, Could it be peritonitis? So he's actively infected. So this is a 30-second checklist when the patient comes to us. I can try to immediately categorize this patient. Is the child having fever? Yes, that means he has sepsis. Is there pus or infection anywhere? Is it toxic looking? Is there a previous lab which is showing me suggestion of infection? If my blood culture has come back after some days, it quite often happens that a child with sepsis is admitted who lands up with hypertension later on. Is there any extreme of age? And an absence of an history of sore throat in the back rules out PSG. And if there is any worsening renal failure or rapidly worsening crescentic glomerulonephritis. So all these points would point to IRGN. So the first point of difference is the timing of hypertension. So the hypertension happens during active infection or an ongoing sepsis, which could be in any form, either a pneumonia, endocarditis, cellulitis. If the child has fever, pus somewhere or a positive culture, think of IRGN and not a post-streptococcal GN. This another child was brought convulsing to casualty, blood pressure 160/90, and again, low C3 ASO is awaited. What is different here clinically as compared to previous two children is this child came convulsing to casualty and he was extreme high blood pressure in this child. So the point is the severity of hypertension is very severe, or it can be symptomatic hypertension in IRGN. So if you have a certain child who has come with hematuria, edema, and a target organ affection like a seizure or a convulsion, hypertensive encephalopathy, start thinking of IRGN and not our good old PSGN. And staphylococcus is bug more common to present as IRGN, and especially these are children who are already hospitalized. So what we did, he came convulsing, we shifted him to ICU, controlled his seizure. Now gave him a furosemide, 1 milligram per kg stat dose. He had a good urine output. I was happy. So now what would be our next choice? To give 2 milligram per kg, increase it because I want him to make him edema free and control his hypertension, or should I evenly space out my diuretic in this child? So this is a confusion that often happens. So to understand this, let us understand the concept of ceiling dose. What happens? Look at the green line. When I increase my loop diuretic concentration, as it increases, my diuresis kind of increases, but beyond a certain dose, it will plateau off. So there is no point giving higher and higher dose in an want of increasing the urine output. Rather, we space out our diuretics evenly to have a sustained diuretic effect. This is one again practical thing that I often come across, that to give furosemide and spironolactone as a combination that is available, like very common market preparations that are available are 50 milligram furosemide with 20 milligram spironolactone. Ulta. 20 milligram Lasix and 50 milligram of spironolactone, or should we give it separately? Now, again, this is a personal opinion. The milligram per kg doses do not match with each other. Like, for example, if I have a 20 kg child, if I decide to give 1 milligram per kg of furosemide, in that same tablet, there is 50 milligram of spironolactone, which is almost 2.5 times of his weight, which is his entire day dose. So, in my personal opinion, I don't like giving combination. Rather, I'd give spironolactone half an hour earlier than furosemide so that there is a sequential blockade and the edema resolves better. So what happens to the hypertension once we control the edema in this way or the fluid in this way? Usually, post-streptococcal GN will respond very nicely to salt restriction and loop diuretics. That is just a furosemide, Lasix that we use or furosemide that we use. In IRGN, it may be resistant or only partially responsive. Now, what decides this response is how nicely we can control our infection with antibiotics. So antibiotics are a very important thing in IRGN as opposed to PSGN. So I will skip this. Okay. So summarizing, in PSGN, furosemide is the main important thing. In IRGN, you have to give the right antibiotics and fast. Collect the blood culture and start first dose of antibiotic. It is like sepsis, treating sepsis. And yes, give furosemide infusions or repeated doses rather than giving one single large dose of furosemide. So if I have a child with 30-second checklist that I've identified, first I'll check hypertension severity. If there is too much hypertension or any encephalopathy, I know I'm dealing with IRGN. What do? I see if he's seizing, he's vomiting, or is he having a poor consciousness, GCS is low. The first drug that I usually give to such children is I will push in a diuretic so that the blood pressure in the edema comes down, begins with pulmonary edema comes down, and I give one first dose of my broad spectrum antibiotic. Now the question is, should I give an IV antihypertensive to this child? If there is any target organ affection, whatever stage of hypertension it is, or if it is more than stage 2 hypertension, yes, I will prefer to start him on a continuous infusion of antihypertensive. I prefer labetalol in our ICUs to start, maybe a bolus followed by infusion. And how fast do I want to reduce this hypertension? This is like all other hypertensive emergencies. I do not want the blood pressure to come to normal immediately. So I target reducing the MAP by about 25% in the first 8 hours and then subsequently over the next 48 hours. What response do I expect? As opposed to a classic PHGN, we may have a poor initial response to urine output just by Lasix alone. Maybe the diuresis starts little later in suspected IRGN patients. Once everything is under control, once sustained diuresis starts, then maybe I can add an oral antihypertensive to this child once the blood pressure has come down and the symptoms are better. I'll keep on following up his blood pressure. What am I wanting to look at? Whether at 6 weeks his C3 is coming back to normal or no. Till then, I need to ensure that his blood pressure is okay and his kidney health is okay. Classic PHGN almost never needs a biopsy. But IRGN may need if there is oliguria, if there is a worsening renal failure, or the proteinuria increases at 4 weeks. Persistent proteinuria despite a therapy at end of 4 weeks. So to summarize, we need to start treatment at the same hour when we see a cola-colored urine and a puffy face and a high blood pressure. Do not wait for reports. First drug always is furosemide. Give a bolus of 2 mg per kg Lasix. Tell the patient to avoid salt at any cost. If there is still fever, please give antibiotics immediately. If there is urgency, you give furosemide and IV labetalol. And if there is no urine output for 24 to 48 hours or the creatinine is rising, please stabilize the child and shift the child to a higher center as early as possible. So to summarize, in an acute GN, which is not typical, look out for pus, that means look out for any focus of infection, give to flush, give a diuretic, don't wait for reports and complicate things. And if he doesn't pass urine, refer. So find pus, give the flush, forget the fuss, and refer if it doesn't gush. Thank you.
Thank you, Dr. Amol. Basically, it was really very informative session. So, Dr. Pankaj, sir, do you want to add anything?
These are 2-3 points. Generally, when we say acute glomerulonephritis, we consider gross hematuria as an important criteria. But gross hematuria is seen in hardly 60 to 70%, or 60% rather. So almost 40% will not have gross hematuria. So whenever a child present with hypertension, particularly a pre-adolescent child, more than 5 to 6 years, first differential still I think we shall keep AGN because it is easily treatable and it has a good outcome and diagnosis will be clear with a simple test of C3. And if someone asks me which will I prefer, ASLO or C3, yes, ASLO has a historical value, but practically ASLO neither confirms nor rules out acute glomerulonephritis secondary to post-streptococcal infection. So the investigation of choice definitely will be C3, which has very high sensitivity as compared to ASLO. Press, yes, sometimes we do see and which requires very aggressive management. And the good thing what Amol said, if child has persistent oliguria, despite giving furosemide, think something beyond simple post-streptococcal glomerulonephritis, and probably that will be the right time to refer immediately because most of the post-streptococcal GN responds very well to diuretic. So poor response to diuretic, significantly rising creatinine, significantly high proteinuria, do consider nephrologist opinion.
Yeah, thank you, Pankaj, sir. The really best advice. Prachita, ma'am, do you want to add anything?
So excellent presentation, Dr. Mol, very crisp and clear to differentiate the two etiologies. So whenever a child comes to us with a hypertensive emergency, as the patient discussed by Dr. Amol, while we do have to simultaneously think of the probable etiology, the main things does remain the ABCs of resuscitation because that is very, very important. And after that, simultaneously trying to look for the etiology. because it's a very it can cause a lot of morbid and a lot of mortality, this high blood pressure, like press, as sir said. So basic ABCs before looking for the etiology. And of course, I completely agree that C3 is always an investigation of choice, especially in centers where you can send only one investigation, something we can send, or whether the patient affords. C3 would be the investigation of choice to look whether it is post-infectious GN or not over ASO. So yeah, that's about it. Everything else was cleared very well. And yeah, no role of just increasing the furosemide over and over again just to get the urine output to increase. If you give a dose of furosemide and there's no urine output, just step back and think of something else. Yeah, that's all.
Thank you, ma'am. Now going to third session from the city of Nashik. Dr. Pawan Devre is from the city of Grapes. Dr. Pawan Devre is there. He will be delivering on postnatal evaluation of fetal hydronephrosis. Over to you, Dr. Pawan.
Yes, thank you, sir. Am I audible?
Yes, yes. Yes, go ahead.
Okay.
Make it slideshow. Pawan.
Yeah. So my slides are visible to everyone?
Yes, but make it slideshow.
Slideshow.
It is on slideshow.
Okay. Can you just change the slides?
Yeah.
No.
I'm changing.
Yes, but we are not seeing the change in slides. Pallavi ma'am, will you share the slides?
Hello.
Pallavi ma'am, तुम्ही स्लाइड शेअर करा थोडे. सरांचा थोडा
पवन
इश्यू
सर,
येते.
पवन सर, नाही
Yes.
पवन सर, फक्त डबल
हो.
क्लिक करा तुमच्या या PPT वर, किंवा खाली बघा तो ग्लास सारखा आयकॉन आहे 68% शेजारी, त्याच्यावर क्लिक करून बघा सर एकदा. अदरवाइज आय विल शेअर. Try once or else I'll share.
ठीक आहे मॅडम.
Just click on the slideshow or else I'll share, sir. Okay, I'm sharing, sir. Just stop your
Pawan,
sharing. I'll do
Dr.
that.
Pawan, please stop sharing.
Sir, please start if it is visible.
Okay.
In next slides. Pallavi ma'am, you want to keep next slides? Yes.
Yes. So, so I'll be able to change from my side, or
No, you just tell Dr. Pallavi. Pallavi ma'am will change the slides for you.
Just say next so that I can change the next slide, sir.
Okay. So, good evening, everyone. So this topic is very important because the fetal hydronephrosis is quite common. The incidence is almost 7.7% in some pregnancies, and it is the cause of panic and anxiety to the expecting parents. So a right approach is necessary to avoid over investigation, but at the same time, you should not miss any major pathology. Next slide, please. Next. Yeah. So just to briefly, I will tell you the causes of urinary tract dilatation. Majority cases, the hydronephrosis in the during antenatal period, it is transient, and it does not lead to any severe unilateral or bilateral hydronephrosis in the baby. But conditions like POG obstruction or vesicoureteric reflux, yes, they can turn out to have significant renal problems. Next slide. So just to tell you, the fetal hydronephrosis in the second trimester, if it is more than 7 millimeter, and if it is more than 10 millimeter in third trimester, it is significant. Next slide. So certain red flags, if the antenatal scan is showing bilateral hydronephrosis, if the bladder is thick, distended, thick-walled, and there is delayed emptying, then we are suspecting something very serious condition, and we are suspecting posterior urethral valve. Next slide. So this is how the keyhole sign looks, and if the antenatal scan is showing this picture, then you should be very aggressive in the postnatal evaluation. Next slide. Also, if there is such images which are seen on the scan, if there is renal cyst or the kidneys are echogenic, then these are the red flags. Next slide. So the risk of renal anomaly after birth is almost 90% if there is severe fetal hydronephrosis. Next slide. Once the baby is born, you should look for clinical cues like water faces. You should look at the baby's spine if there is any occult spinal dysraphism. Do a genital examination. Look at the anal opening whether it is absent or if there is any patellus opening. Next slide. Now postnatal evaluation. So this is the list of evaluation which are there in your arsenal. Ultrasound, micturating cystourethrogram, EC renogram, blood test. Then you have a choice of antibiotic prophylaxis, and then further you have to decide whether any surgical intervention is required or not. Next slide. So ultrasonogram is absolutely necessary in all newborns, even if the baby passes urine. So there is some misconception which I have come across is that if the baby passes urine, there is no need of doing ultrasound, but it is not true. Ultrasound is required even if the prenatal antenatal scan shows resolution of hydronephrosis by the last trimester. Still, you should do the baby's ultrasound. Next slide. So when you should do an ultrasound? So if you're suspecting lower urinary tract obstruction, if there is that keyhole bladder or thick walled bladder, over distended bladder, or if there was oligohydramnios, the red flags which I had mentioned, if there are any of the red flags is seen in the antenatal scan, you should do the ultrasound within 24 to 48 hours of the birth. In other cases, if there is mild bilateral hydronephrosis or unilateral hydronephrosis, then you can wait and do the scan within 7 days, within 2 to 7 days. Next slide. Now, ultrasound, usually this is what I communicate with the radiologist. Instead of just writing an USG KUB, I write it in this format that I want the kidney size, the pelvis anteroposterior diameter, I want the parenchymal thickness, I want the ureter size, I want the bladder thickness, full bladder volume, and postvoid residue. Just mentioning that the kidney size is normal, no hydronephrosis is not important. So what is the significance of this anteroposterior diameter? So if it is 10 to 15 millimeter without any calyceal peripheral dilatation, then it is mild. But if there is peripheral calyces are dilated, or if there is any abnormal renal parenchyma like echogenic bladder, echogenic kidneys, then it comes as severe hydronephrosis. Next slide. Now, if the baby is showing a normal ultrasound, or if there is any very minimal PCS fullness has been reported, then you should still repeat an ultrasound at 4 to 6 weeks of age. And if there is mild hydronephrosis, which I had shown in that first, less than 10 millimeter, then you should do a follow-up USG every 3 to 6 months till that hydronephrosis resolves. Now, the next investigation is micturating cystourethrogram. This has to be done urgently if there is bilateral hydronephrosis, especially if it is a male child. If you are suspecting lower urinary tract obstruction like posterolateral valve, then yes, the MCU should be done within 24 to 48 hours. In other cases, if there is, you should do it between 4 to 6 weeks. And the reason to do this is to rule out vesico-ureteric reflux. And the only precaution which you should take before doing an MCO is that better to start an antibiotic and treatment dose to prevent any urinary tract infection because of iatrogenic causes of because of the catheterization. Next slide. So, suspecting posterolateral valve, you should be strongly suspecting, especially in a male. If it is the child is not passing urine, then urgent catheterization should be done. And also, you should do a biochemical test. You should order a serum creatinine electrolyte. You should order a venous blood gas or arterial blood gas, and you should correct all these abnormalities. And if the MCU suggests there is an dilated posterior urethra, you should involve a pediatric surgeon and do a cystoscopic ablation of the valves. And long-term follow-up is also very, very important for the management of gallbladder syndrome. These kids, babies, they have a high risk of progressing to chronic kidney disease. So a pediatric nephrologist and the pediatric surgeon should be involved for the long-term management of these patients. The next is EC scan, which is the dynamic renal scan. And this should be done if there is hydronephrosis and your MCO is normal. You should be suspecting POJ obstruction, which is the pelviureteric junction obstruction. So the EC scan gives us the value of the differential function of the kidney. So it will give us that whether the kidneys are functioning well or not. And the severity of obstruction can be judged using this scan. And we can decide whether the surgery of pyeloplasty is required or not based on the EC scan report. Next slide. So apart from the PO valve, which I have told, which is urgent, the surgery is required, and POJ obstruction, if there is low differential function, if the that involved kidney is poorly functioning, then yes, pyeloplasty is required. Other indication for surgery is that if you detect an ureterocele on ultrasound or the MCO, then that ureterocele has to be dealt with. And if there is any ectopic ureter or if there is VOJ obstruction, again with low differential function of that kidney, then surgery is required. Next slide. Next. Okay. So next question comes is antibiotic prophylaxis. Now you know that this baby has got hydronephrosis. It can be unilateral or bilateral. And what to do about the antibiotics? So the recommendation is that while the investigations are awaiting, you should give antibiotic prophylaxis. Next, if there is reflux of any grade less than 1 year of life, till 1 year of age, all infants should be kept on antibiotic prophylaxis. Beyond that, if the reflux is high grade, then yes, you should continue the antibiotic prophylaxis. In low grade, there is a debatable benefit. Some say that you should give, or even if it is not given, that is also okay. But high grade, definitely yes, should be given. Next slide. So this is just an algorithm which has come up with in the recent guidelines of postnatal evaluation of hydronephrosis. So if it is, there is no height. So this show the previous slide only. Yeah, just keep this. So if there is no hydronephrosis, then no further intervention is required. If there is mild hydronephrosis, then you should do a follow-up USG every 3 to 6 months till there is resolution. Then if there is moderate hydronephrosis, if it is more than 15 millimeter with peripheral calyceal dilatation, but there are no other renal abnormalities, then you should go ahead with MCO and then further decide whether you have to do a whether there is reflux or whether there is obstruction. And this is absolutely necessary, the ultrasound as well as the MCO, if the kidneys are echogenic, if the antenatal scan was showing oligohydramnios, and further management on the lines of CKD is required if there is any further renal abnormalities. Next slide. So a take-home message is that you should do a postnatal USG even if the baby passes good urine stream. Better to involve a pediatric nephrologist, especially if there are red flags like echogenic kidneys, bilateral hydronephrosis, oligohydramnios in the antenatal scan, and 95 to 98% cases are well manageable either medically or surgically, and they have excellent outcome. So yeah, thank you.
Hello. Thank you. Really good mesmerizing talk. Over to you, Dr. Pankaj. Anything you want to add?
Yeah, actually, good presentation is a very big topic, and he has covered very well with all aspect of antenatal hydronesis in such a short span. Important thing in antenatal scan, when we get USG along with hydronephrosis, I think the most important finding will be urinary bladder. Both are abnormal if it is persistently distended or persistently empty. Both point towards a grave bladder issue which can have very long-term consequences. Generally, it takes 45 minutes to 1 hour for one bladder cycle in fetal age. So, sonologist needs to take some effort to reassess the child at least 1 hour afterwards so that they can assess whether bladder is emptying adequately and completely. Second, when we get a hydronephrosis, it is considered as a soft marker of anomalies. So trisomies or other genetic abnormalities. So if we see hydronephrosis, also look for if other systems are involved like musculoskeletal, cardiac or GI, because that requires further workup from genetic point of view, because that may be a pointer towards trisomy. After delivery, whenever we are suspecting bladder outlet obstruction, particularly a boy where posterior urethral wall remains quite common, we should catheterize, but preferably catheterize with feeding tube rather than using Foley's catheter, and transfer immediately to a unit where child can be subjected to surgery. And those days are now gone where surgeon used to do cystoscopy or cystostomy or ureterostomy. Nowadays, most of the surgeons are confident enough to undergo subject the child to fulguration directly rather than planning a two-stage surgery. So transfer immediately to a center where we have a good pediatric surgeon which can fulgurate the child in early neonatal age itself. Yeah, that's from me.
Yeah, good.
Pratish.
And a timely intervention by pediatric surgeon is very important. So,
Yes.
now, Dr. Prachita, ma'am, do you want to add anything?
So one important thing is that the importance of USG after birth is extremely important, because in our culture, obviously birth is celebrated and you'll have all the family members, and there's going to be more than one voices which will say the child is looking so normal, छान दिसतोय, सुसू चांगली होते, काहीच गरज नाहीये, किडनी चांगलीच असणार. There are more than many voices which say that. So insisting antenatally itself that however the child is after birth, a sonography in the first week will be essential to look for hydronephrosis later on is very, very important, because that sometimes gets missed. Individualized therapy for every child. So it's not a number game. We see often that, AP diameter is 10 or AP diameter is 12. So it's not a number game anymore. Sometimes the AP diameter, anterior posterior diameter of 12 can be more severe than an anterior posterior diameter of 15. So because that can cause more parenchymal thing, looking at the parenchymal thickness is very important. So it's not a number game just to look at the AP diameter and decide what a management is. Every child with hydronephrosis doesn't require an MCU and EC scan. So every child doesn't require an array of tests. As Dr. Pawan has mentioned, it's only specific conditions you need an MCU. In specific conditions, you need an EC scan. But a blanket investigation of an MCU and AC scan is really not required, which frankly does happen nowadays with the ease of accessibility of MCUs and AC scans. But individualized care is very, very important. So not every child is the same. Not every hydronephrosis is the same. Even if the dimensions may be same, it is not like that. So it's very, very important to individualize care for every child. And the last thing which is very important is detection of early UTI. So even if a child is on prophylactic antibiotics to decrease the chance of infection, there's always a chance that this neonate or this newborn can have infection. So counseling regarding if there is fever, if the child is not feeding well, irritable, lethargic, so anything different than usual, please send off a urine routine. You can't afford to get this UTI missed because they have very soft signs. Fever may not even come up in the first month. So any symptom which is different than usual, please send off a urine routine and diagnose a UTI if it is present. So don't miss that. That's all.
Yeah, absolutely right, ma'am. So, most important in such cases is counseling, and that should be started from antenatal period only. So, and always think of UTI. Good. Thank you, ma'am. Now, we are in the mid of the academic session. So, for further proceedings, I hand over the mic to my co-moderator, Dr. Suchita, ma'am. Over to you, ma'am.
Oh, thank you, Sachin. And our next fourth speaker is Dr. Shishir Mirgunde from Kolhapur, and he'll be talking on nocturnal enuresis, which is nightmare for the consultant as well as the parents also, and particularly if the child is adolescent. So, in day-to-day practice, this is very common situation. Dr. Shishir, please enlighten us on this topic. Dr. Shishir.
Thank you. Thank you. Pallavi, please share the presentation.
Yes, sir. Yes, sir.
Thank you. Good evening, everyone. So, as told by Dr. Surekha, this is really frustrating and sort of nightmare situation for parents as well as child, especially if he's or she's older. So, let's see one by one the practical issues related to this issue. Pallavi, next slide. So what is it actually, nocturnal enuresis? It is involuntary urination during sleep in a child who is at an age where nighttime bladder control should be established. Usually it is defined in children more than 5 years old or equivalent developmental level with repeated episodes, especially at least one episode per month for consistently 3 months. Then we should think for about this nocturnal enuresis. Next slide, please. There are two types. Primary, the child has never been consistently dry at night for a long period, then it is primary. And secondary means enuresis develops after a period of an established dryness, more than 6 months at least. And here, more likely to have some underlying cause. Now, there is one more distinguishing factor that is monosymptomatic or non-monosymptomatic. Monosymptomatic means he or she has only nighttime wetting, versus non-monosymptomatic means daytime urinary symptoms are also present along with night wetting. So non-monosymptomatic enuresis requires different or some added management strategies. So next slide. Now, just to know what we are hopeful about this condition. There is some spontaneous remission rate that around 15% per year cure rate in children who are otherwise healthy. Next slide. Now, just we will try to understand what are the causes or what are the contributory factors towards this condition. In most children with monosymptomatic enuresis, there is no major structural abnormality. The key mechanisms, usually there are more than one mechanism involved in this nocturnal enuresis. Nocturnal polyuria, producing more urine overnight than the bladder can hold. Then reduced nocturnal bladder capacity or functional capacity, or detrusor overactivity at night, impaired arousal or awakening response. The child's sleep mechanisms don't reliably wake them when bladder is full. Other risk factors like family history, high heritability, male sex, constipation, bowel problems, sleep disorders. Nowadays, this is hyperactive ADHD or ASD also do have this problem. Now, as in other situations, this detailed history is also important in nocturnal enuresis. Pattern of wetting, how often a child is having these symptoms, how many nights per week, any daytime urinary symptoms are present like urgency, frequency, or incontinence, or how much fluid intake is the child is receiving, voiding habits, prior dry period, how much period of time he was dry, then family history, their constipation or bowel issues, and sleep issues, as we discussed in previous slide also. Next slide, please. Physical examination, you should assess the growth, abdominal or bladder examination, whether there is palpable bladder distension is there. Genitalia, we have to observe. Spine, important is spine because for signs of occult neural tube defects or spinal problems. And neurological examination of lower limbs and perineum, especially sensations in perineum and inner thighs. Next slide, please. Now, just basic investigations initially, urine analysis. It is just to rule out infection and whether there is glucose in urine or some concentrating defect is there. And consider a 24-hour voiding or drinking diary. This is very important. Or simply frequency volume chart that every parent can do it. And especially we are suspecting polyuria in a child. Now, what are red flags requiring early referral or further evaluation? Daytime wetting or overflow, as we previously discussed. Recurrent UTIs are there, then this is red flag. Neurological signs, spinal anomalies, bladder distension, polyuria, polydipsia, suggestive of some systemic illness. Next slide, please. Next slide. Now, first line management is always behavioral or educational type of thing. So, educate the child and family. Reassure that bedwetting is common, treatable, and it's not a child's fault. So, we must reassure them first. Then, lifestyle and behavior. Now, regular daytime voiding they should be promoted, and void just before bed, and restrict fluids in late evening, and treat constipation if present. These are very important steps from our side. And motivational therapy. There must be some reward system, or we should keep charts for dry nights, praise the children, then avoid punishing wet nights. This emotional and physical abuse is also likely in such children, so this should not happen. Then set a trial period, say 3 to 4 months, before declaring them as failed because of behavioral and educational treatment. So we should give some trial period. Next slide, please. Now, specific interventions if first line treatment is insufficient for monosymptomatic children, we are motivated who are motivated and families are committed, then enuresis is alarm is important. That is strongly recommended initially. It helps conditional awakening to bladder fullness. Once bladder is full, child after alarm awakens, and that condition makes him to awake next time. So that is very effective, and we can try first. And if it is not responding to that, then we can go for specific pharmacotherapy. There's desmopressin, which is available as oral as well as nasal, and oral is preferred. And especially if nocturnal polyuria is suspected, that is larger nighttime urine volumes in voiding diary, and bladder capacity is reasonable, then we can try this. Ensure fluid restriction because this causes volume overload and dilutional hyponatremia. It may be symptomatic also, so we have to take precautions of this while using desmopressin. Then anticholinergics like oxybutynin or combination therapy. Consider if bladder overactivity or reduced capacity is identified, especially symptomatic or refractory cases. Next, please. Next, please. In previous slide, some pediatricians used this imipramine, but because of its side effect profile, it should not be used at all. But in refractory cases, after expert opinion, we can think of it, but it should not be encouraged. Now, after the treatment, we should give some for monitoring period that track the number of wet nights, voiding diary updates, fluid intake monitoring, and once dry or significant improvement, maintain therapy for a period, say 1 month post dryness, then consider structured withdrawal, especially for desmopressin, to minimize the relapses. If no response after adequate trials, say 3 to 4 months of alarm or medication plus behavioral measures, consider referral for specialist evaluation.
Thank you.
Thank you.
Thank you, Megunde sir. And indeed, a difficult situation this is, and parents expect whenever they come to us, they expect that from the next day the child should be dry. So, Dr. Pankaj, your expert comments on this.
Thank you, sir. Quite a good presentation. Again, it's a big topic. No, primary nocturnal enuresis, the good thing about it, most of them go in remission, and it is almost up to 98% or 99% they remit. But time varies, and this time becomes a really troubleshoot for parents as well as kid. And the main purpose of treating primary monosymptomatic nocturnal enuresis is not probably medical cause. It is more of a psychosocial reason we need to treat. Now, but before we label it as a primary monosymptomatic nocturnal enuresis, we shall be very sure that we are not missing anything. And the pointers for them is particularly any daytime symptom, whether it's urgency, frequency, hesitancy, repeated UTIs, or constipation. Think it is not a simple primary nocturnal enuresis. We need to work out the bladder thoroughly before labeling it as a primary NE. Another feature which I see sometimes encopresis is missed or overlooked by the parents. And if child has daytime incontinence, urinary or bowel, then take it seriously. Probably we are heading for some neurological issue or some bowel bladder dysfunction. And treatment is entirely different in this group of kids. And the most important investigations, when we are almost near sure that it is a primary monosymptomatic nocturnal enuresis, we practically do not need any lab to confirm it. It is a history, and at the most what we can do is voiding diary. Beyond that, we may not need to evaluate in detail, which includes sonography, labs, KFT, anything. As far as all other things fit in this position, maximum we may need is a voiding diary. That also just to rule out other possibilities. About the drug which nowadays comes as a first line after alarm therapy is, we all know, desmopressin. While giving desmopressin, as sir has mentioned, restrict fluid strictly after giving desmopressin, otherwise it can cause hyponatremia and complication related to it. And best way is do not give these tablets in kids hand. Let the responsibility with the parents to hand over the tablets appropriately, particularly in the age where child has not grown enough to understand the side effects of overdose of this desmopressin. And again, before labeling it as a nocturnal enuresis, rule out bladder dysfunction in history and if required further investigations. Thank you.
Thank you, Pankaj. Dr. Prachiti.
So I think across the board, all of us know how frustrating this condition is. I think everybody started their statement saying that, because invariably the child will come back after 1 or 2 weeks saying he's not yet better, he's still voiding. So it's a game of patience, because but it is very frustrating, as you know, the child may be 5-year-old, 6-year-old, still not toilet trained. The younger child is already toilet trained. The 4-year-old is already toilet trained, but the older one is still bedwetting. So it's a very distressing symptom for both the parents as well as the child. The certain conditions can also be seen associated with nocturnal enuresis, like ADHD. So in ADHD children, somehow the sleep arousal is not as good. So these are the ones, even after 5 to 6 years, can still have bedwetting at night, and it gets a bit difficult to treat them. Second condition is when there is adenoid hypertrophy, and they can have some early obstructive sleep apnea. In these conditions as well, the sleep patterns are very fragmented. So there is delayed arousal from sleep. So always look for them, as an ask for history suggestive of any of the two conditions, like ADHD or adenoid hypertrophy. Secondly, we always say the importance of bladder diary, but in a child who's bedwetting, the common questions come that he's wetting the bed. How do I calculate nocturnal polyuria, because he's wetting the bed? So sometimes what helps is, tell the parents that when we are doing the bladder diary at night time, put him in diapers, and these diapers can be weighed. So most families may or may not have a kitchen weighing scale where you can weigh the weight of the diaper pre and post passing the urine. So that can sometimes help us give us the night urine output. I don't think if the child is well, I would want to catheterize any child at night. So how to know the urine output? We can weigh the diapers at night, and then we can figure out whether the child has a nocturnal polyuria or not. So nocturnal polyuria, essentially, we have to measure the nighttime wetting, the urine which is passed at night, as well as a morning sample. So it is a nighttime amount of urine as well as the morning. So the nighttime, if it's bed wet, it goes in the diaper and you weigh the diaper. And morning, when the child wakes up, you collect that sample as well. And when you add the two, you get the nighttime urine output and can label this child as nocturnal polyuria or not. So measuring, though we say bladder diary, how to do it sometimes is very important to tell the parents. That's about it. But I think very good presentation and very tricky topic to address.
Thank you.
Indeed. Indeed, and in particularly adolescents who have already gained the control and now start nocturnal enuresis, always suspect a sexual or physical abuse also. So our last batsman is Dr. Ashwin Mishra, who will be talking on medicines and renal injuries. Dr. Ashwin, over to you.
Ashwin sir, your PPT was full screen and it was visible. Kindly make it full screen again and start, please. Yes, it is full screen, sir.
Correct.
Kindly start. Ashwin sir, can you hear us? Ashwin sir, can you
Muted,
hear us?
Ashwin.
It is visible, sir. It is visible. Kindly start your presentation.
आवाज म्यूट आहे, म्यूट.
सर फोन करा कोणीतरी त्यांना.
त्याचा नंबर नसेल माझ्याकडे.
असेल असं
सुचिता
माझ्याकडे.
मॅडम प्लीज
हा,
कॉल.
सर. Yes, I'm calling to him. Hello, Dr. Ashwin, please unmute yourself. You are not audible.
I did unmute, but
Yes, yes. Now audible.
No, he is audible in my phone.
अच्छा, okay, okay.
muted. Did unmute.
You're unmuted? Oh,
Yes,
yeah.
ma'am.
Once please try on this platform, Zoom platform. I'll put up my switch off my phone. Okay.
Yes.
Anything from Pallavi?
Ma'am, he has to rejoin if it is not audible.
ज्वाइन करके अपनी बीवी तिहाड़ जेल.
Okay, I'll once call him.
तोपर्यंत मी काही क्वेश्चन विचारू शकतो का?
You please rejoin. Yes, doctor. You please rejoin once. Yes, Dr. Ravindra.
Hello.
Yes, definitely.
Madam, Prachiti madam, can you please tell me what are the brands available of this desmopressin, and other than tablet form, other formulations? Can you elaborate, and what is the role of this alarm method in case of nocturnal enuresis? And
Okay. The desmopressin say that there are two basic formulations which are available. One is the tablet form and one is the intranasal form. The tablet form is somehow preferred. Current intranasal can sometimes lead to accident overdose as well. So I would definitely prefer tablet over the intranasal spray. Again, there can be practice variation, but I'm always worried that पहिल्यांदा गेलं आणि दुसऱ्यांदा puff केलं का that can always happen. So which doesn't happen with the tablet form. So I do prefer the tablet form. And secondly, regarding the bedwetting alarm, there are a lot of brands available. They're even available on Amazon, ranging from 1,000 rupees to 8,000 rupees. And there are different kinds available. One which is kind of attached to the bed sheet or the bed sheet where the child is sleeping. One can be directly attached to the undergarments of the child. But again, the cost varies, the brand varies. There's no typical brand I actually adhere to, whichever is easily available, because they work equally well. Whichever is easily available, I would advise that. Also depends upon the affordability, because the cost really changes. It's right from 1,000 to 8,000 rupees. It will be there. Pankaj sir, any particular brand
are you advising?
Sorry, sir.
Are you advising practically this alarm method?
Yes, I have practically, but I would say what does happen practically ki everybody else gets up except the child, unfortunately. But we don't, so that mother will get up, the father will get up, the child who is having difficulty in sleeping is going to still be sleeping. That is the fact of the matter. but that is the best bet we have right now. That is the best way forward. So at least a family gets up when they wake up the child. Yeah, it is difficult, but yes, I have practically prescribed it. Some children have gotten up with the alarm, but I would say mostly the parents end up getting up. But that it is because desmopressin will really work for the short term. It will only work temporarily. So if they're stay over or camps or they're going to somebody's house, it can work temporarily. It is never the treatment as such. So eventually it is just conditioning your body to wake up when your bladder is full. So when the bladder gets full and the sensation of bladder fullness comes, you need to wake up. So we're just helping to train the child. Yes, it can take a lot of months, but yes, I do prescribe it, but it is difficult. I wouldn't say it's easy at all.
Yeah, Dr. Ashwin has joined again. Will you please start sharing your slides, Dr. Ashwin?
Sure, ma'am.
Thank you, madam.
Yes, yes.
Is it audible now? No?
Yeah, you are audible. Make it a full screen. Yes, it's okay.
Okay. Thank you. So, good evening, everyone. My topic is medicines and renal injury. Nephrotoxicity is basically the rapid deterioration in the glomerular and tubular function of the kidney due to exposure to a particular nephrotoxin. In children, it can present with the clinical symptoms of acute kidney injury. It could be with or without oliguria. If there is glomerular component involved, then the child might present with nephritic syndrome or nephrotic syndrome or the mixed picture. It is highly underreported given that we hardly monitor the kidney functions while administering so many nephrotoxic drugs in our hospitals and ICU settings. But there are more than 80% hospitalized children who are exposed to nephrotoxic drugs, and around 16% of hospitalized AKS can be attributed to particular nephrotoxic drug. Coming to the types of nephrotoxin, there are three types. What we are going to deal with is pharmaceutical agents, in which antimicrobials, NSAIDs, ACE inhibitors or ARBs and chemotherapeutic agents are commonly involved in the children. So this is basically the list of selective drugs which is commonly involved in the pediatric nephrotoxic AKI. This is easily available online and in any textbook. Coming to the mechanism of injury, I'm not going to go into the details of each one, but I want to try to explore the difference between first two, because which has some implication in terms of management. So first is direct tubular toxicity. In this, the nephrotoxic drug specifically enters the intracellular compartment in the proximal tubular epithelial cells and then causes oxidative stress injury leading to apoptosis and necrosis, which can be seen on kidney biopsy as acute tubular necrosis. The common drugs which leads to direct tubular toxicity are aminoglycosides, amphotericin B, polymyxins, antivirals, chemotherapeutic agents like platins, ifosfamide. The next is acute interstitial nephritis. This is basically an allergic reaction to the drug where drug itself acts as an allergen, activates the immune system, and then leading to the deposition of antigen antibody immune complexes in the kidney interstitium. This is also can be seen in the kidney biopsy as heavy infiltrate of inflammatory mediators in the interstitium and along the tubular basement membrane. Coming to the important part, which is the prevention and management. As we know that the well-known tenet of nephrotoxicity is that there is no specific treatment once the damage is already set in. So our focus is to intervene at the very primary prevention level, that is to completely avoid the drugs which are known nephrotoxics. If it is not possible or the alternative drugs are not available, then at least we can minimize the dose and the duration of drug. In many settings, we see that the multiple nephrotoxic drugs are being administered without any monitoring of kidney functions. In those cases, we at least have to decrease the number of drugs, limiting the total nephrotoxic burden. However, if the kidney injury or damage has already set in, we have to look for 6R approach, which has been developed by this Mehta et al. In 2017. In this, first we have to identify the risk factors and address them. Second is recognition of the specific phenotype, and they have given the criteria to identify and establish the diagnosis according to the particular phenotype. Then how do we respond to the situation and what are the measures that we can take? Obviously, some patients might require renal support in terms of renal replacement therapy. So the risk factors, obviously, the most important in pediatric age group is volume depletion, intravascular volume depletion, because given the immaturity of their renal functions, or in the first 2 years of life, these pediatric patients are more prone to develop volume depletion. Second is exposure to multiple nephrotoxic drugs given together, then high level exposure to multiple nephrotoxins in high doses and for a longer duration, for example, aminoglycosides, then excessive medication dose even for the low GFR, then concomitant CKD or liver diseases, then if the child is in a high risk setting such as ICU setting, immature renal functions as we discussed, and genetic vulnerability. So we have to recognize the phenotypes. This is also they have given 4 phenotypes by Mehta et al. In 2015, and they have given the criteria to describe and establish the diagnosis. So first is acute kidney injury, under which ATN, acute interstitial nephritis comes. So they have described stage 2 AKI to establish the diagnosis in the first phenotype. Second is glomerular disorder, that is the new onset proteinuria or hematuria after the exposure of nephrotoxic drug under question. Then nephrolithiasis, which will also be described as new onset crystalluria or presence of stones with or without obstruction, without any prior history of nephrolithiasis or without evidence of any metabolic disorders which can lead to nephrolithiasis. And the last one is tubular dysfunction, which can present as a picture of renal tubular acidosis, SIADH, like that. So how to respond in this situation? The decisions, for example, how to take the decision about stopping or reducing the dose of the drug. First, we have to understand the types of toxicity. The type A toxicity, which is dose dependent and predictable toxicity, which is generally based on the pharmacokinetics of the particular drug. And this type of toxicity can appear at a particular specific interval after the exposure to the drug. The response in this case, the dose reduction most of the time will be sufficient, but may require complete withdrawal of drug in some severe cases. The examples are aminoglycoside toxicity. The type B toxicity, it's an idiosyncratic reaction and it's unpredictable. And this can happen even with one single dose of the drug. So discontinuation would be the most prudent response in this case. The example is acute interstitial nephritis because of, for example, proton pump inhibitors. Secondly, we have to identify the risk factors and definitely address them. Then we have to monitor daily serum creatinine in such cases. We have to monitor urine output, and if available or feasible, therapeutic drug monitoring of the particular nephrotoxic drug. Then renal replacement therapy. Some cases, some patients may require renal replacement therapy if they develop any form of fluid or solute overload. Decision about kidney biopsy, even though it's a gold standard, but we have to weigh the risk benefit ratio. So if the child is responding to the above measures for within 7 days, we may not need kidney biopsy, but if it is not responding, we may need to go for biopsy so that we can look at the histopathological pattern and distinguish between the subphenotypes, for example, acute tubular necrosis versus acute interstitial nephritis. Because as we know that acute interstitial nephritis, if it is present, then the child may benefit from steroids. And also to look for the prognosis and to look for chronic changes and the possible outcome. So I have just given the Schwartz equation for GFR estimation. Then normal GFR values. This is available in all the textbooks. I have selected some drugs and their renal adjusted doses according to the GFR. Common drugs. These are also available in all drug doses books. Thank you.
Thank you, Dr. Ashwin. And it is a lot of sensitization is needed while prescribing the drugs to save the tiny kidneys. So, Dr. Pankaj, over to you for the expert comments.
We shall remember that every drug has a potential nephrotoxic potential, which includes not only medicines, even IV fluid like normal saline. So be sure when you are prescribing anything that child really need it, and don't just prescribe for the sake of pediatric, which decides not only in pediatric, in which decides significant nephrotoxicity is dehydration. When child is dehydrated, already kidney is at a compromised state, and a simple drug like mefenamic acid can cause significant injury. And probably nowadays we are seeing a lot of cases, almost 2 cases per week, secondary to mefenamic induced hematuria. The good thing about that, it still recovers very well. But yes, other drugs like ibuprofen, diclofenac, they can have long-term consequences. Recently, I have one patient with a single dose of diclofenac following vigorous exercise where he was dehydrated, lead to AKI, which required dialysis for almost 3 to 4 days. So be cautious while prescribing NSAIDs, particularly in the setting of dehydration. There is a term called triple whammy, where the combination of diuretic, ACE inhibitors, and NSAIDs, they are really has exponential nephrotoxicity. So avoid using all these 3 drugs together. And in the setting of dehydration, avoid or at least withdraw if child is on ACE inhibitors, ARBs, and NSAIDs. Because in the setting of dehydration, the nephrotoxicity of these drugs increases significantly. Now, there are some safety measures which we can use for drug like aminoglycoside or amikacin. Rather than giving divided dose, we can give a single dose. But the problem is that when we prescribe single dose, we need to administer it very slowly. If we administer as a bolus or a rapid dose, the efficacy is not sufficient. So if you are giving single dose, give it slowly. But yes, single dose has less side effect profile as compared to multiple doses. So if child is dehydrated, hydrate it well before considering NSAIDs, ACE inhibitors. And another common practice which we observe, whenever child is not passing urine, without assessing hydration status, child receives furosemide. So when child is dehydrated, please do not expect kidneys to overwork and produce urine. It will produce urine only when child is hydrated well. So priority shall be hydration, and if not improves despite good hydration, then consider diuretic. Otherwise, furosemide itself has a significant nephrotoxic potential. Thank you.
Indeed, that is a very good punch for all the pediatricians, Pankaj. So, Dr. Pratishi, your expert comments.
Pankaj sir has actually covered it all, but ibuprofen and mefenamic acids have become somehow the first medication sometimes offered to the child with fever, and I think probably because of the effect of action, or the parents are happier, the longer duration, the fever is not there, the fever goes away quickly. But as sir has said, I have also dialyzed a child, a 11-month-old child with severe diarrhea and high grade fever, who came in a complete renal shutdown. and the renal output did not even improve after 4 to 5 days, which I thought maybe this is not mefenamic acid, something else. And after biopsy, it was just ATN, it was nothing else. So it was just dehydration along with 5 doses of mefenamic acid in an 11-month-old child, and required peritoneal dialysis for around 10 days. And she does have a component of chronic kidney disease, and is still followed up in the OPD after 2 years. So it is not as nascent and simple as it is. And we have to understand a child who require ibuprofen and who require mefenamic acid, right? The child who doesn't respond to paracetamol. So a child who's having high grade fever, not responding to paracetamol, is very highly likely to be dehydrated because he's not drinking well, he's not feeding well. And so you have high grade fever and lethargy has set in, not and dehydrated. And then when the ibuprofen and mefenamic is given, it is definitely a severe hematuria is coming very, very commonly, but severe AKIs are also coming very commonly nowadays. So that is the only thing. I think rest everything sir has very well elicited.
Thank you, everyone. And we have come to an end of this nephro update. So I must congratulate all the speakers who have followed the very strict time schedules. Congratulations, all the 5 speakers. And I must congratulate all the office experts also, Dr. Pankaj and Dr. Pratiji. And MAHAIP EBs and OBs, in spite of all the mess, they have in this nephro update also, and MAHAIP for giving us, myself and Dr. Sachin, the chance to as a MOC of this update. So there are no questions as such, only one chat in the chat that Pratichi has already, Prachiti, no? Pratichi has already answered. Pratichi, she has, where can we get enuresis alarm and what is the cost? You have already answered. So
there was one question, madam, by Vinod Shelar, doctor. After starting with amoxicillin, many kids have frank hematuria. Is it having any significance? Should we evaluate or just counsel about incident all finding? असं काहीतरी एक प्रश्न आहे. Amoxicillin
okay. Okay.
Frank
Did you get the
hematuria
question?
and amoxicillin.
Did you get the question?
Ma'am, it is often in that we are after starting amoxicillin, we always get frank hematuria. After every 1.5 months, after starting amoxicillin with 40 mg per kg per dose, then we get frank hematuria. Should we evaluate then, or is it the associated finding with the amoxicillin? I mean to ask you.
Yeah. Sure.
Yes, sir.
Yeah. So see, amoxicillin, as I said, every drug has nephrotoxic potential. And if we see even the group penicillin group and cephalosporin group, both of these group have significant nephrotoxic potential. Amoxicillin per se is not associated with, rarely associated with isolated hematuria. Maybe in the setting amoxicillin we are giving, so probably child has fever, child may be mildly dehydrated, and for fever child might have received even antipyretic, NSAID also, and on the top amoxicillin. So probably it will be a combination of all these which child may be presenting with hematuria. But yes, whenever we have hematuria, assess 2-3 things. First, check blood pressure, get creatinine, and check for proteinuria. So if everything is normal, I don't think we need to worry. Or simple way, if otherwise child is asymptomatic and hematuria only one episode is there, maybe we can repeat urine. Generally, most of the time, drug-induced simple hematuria resolves within 3 to 7 days. So if there are no proteinuria, hypertension or deranged KFT, and or if it resolves within 3 to 7 days, we may not do anything further. But yes, at the end, document that it has resolved completely.
Achha, sir. Thank you. Many of the time I find scared finding that I use right and left amoxicillin, and many of the times after 1.5 to 3 months after starting amoxicillin, I get always frank hematuria. I only prefer amoxicillin most of the times, and it is and after within 24 hours, 2 to 3 episodes after getting results, then the patient is all clear.
So probably it is a combination, and typically these drug-induced resolves within 3 to 7 days.
Yes, sir. Yes. Thank you, sir.
So rarely amoxicillin can also cause acute interstitial nephritis. Again,
interstitial nephritis.
Yeah, it is very rare, but it can sometimes cause acute interstitial nephritis. So, if it is happening in the same child, it's basically an immune hypersensitivity reaction. So, in these scenarios, there may be worsening oliguria or the creatinine may go up. Again, a rare scenario, but it's possible amoxicillin. Some hematuria which subsides with stopping the medication doesn't really require too much intervention or investigation. But sometimes, despite stopping, if there is ongoing AKI or ongoing oliguria or the ongoing creatinine is increasing, there can be a acute interstitial nephritis which may require treatment. So if it's the same child who's coming, probably the child has some immune hypersensitivity towards amoxicillin or penicillin group of medication. So that can be kept in mind.
Thank you, ma'am. Thank you.
Yes. My question to Pankaj and Aditi is that I'm dealing with adolescents, and so in nocturnal enuresis, how far the motivational therapy works? Till in the cabin they are motivated. Once they go out of the cabin, they are the motivation loses.
Who to motivate,
So,
parents or the child?
both. Till in the cabin they are say yes, yes, they will do that. So how far your motivational therapy works in them?
Actually, nocturnal analysis is a really nightmare for treatment for not only parents, even for treating physicians also. Yes, generally, before we start drug, even drug will fail if parents and child is not motivated. So initial phase, definitely motivation has to be there. Otherwise, failure rate is very high. Now, even if we consider alarm therapy, which is the best therapy available for any, yes, there are a lot of limitations and practical problem. It really becomes difficult to convince parent to introduce a electrode in undergarment because of so many fear. They are really resistant for it. Second, even that alarm, as Pratishi has already pointed out, it rings very loudly and it wakes up everybody except that child. So actually whole family get disturbed. So unless parents and kid both are motivated, none of the therapies are going to work. Alarm, there will be issue of compliance, and desmopressin, there will be risk of high failure. So maybe initial 1 or 2 months, we should still emphasize on motivation, make them aware that it is not one-time therapy. They really need to put in effort. But yes, if they put in effort, alarm has very good results. So probably motivation is important. Maybe 1 or 2 visit, they have to, we have to bear them rather they.
During our old days, one of our
History
teachers
of
used to say that they should wash their undergarments as a punishment during
Yes,
nocturnal
yes, definitely.
session.
I do practice that. Like it's like positive and negative reinforcement. We are not
Reinforcement.
scolding the child, but we are making sure that if he voids, he is getting difficulty out of it. So that is really awkward because frankly, in most of the kids are not used to that. So
Yes.
probably it's like we are fine-tuning brain that better you get up in the night, otherwise be prepared to wash your uses in the morning.
So, Dr. Pankaj and Pratishi, two messages to us, all of the audience, just two crisp messages to end this CME or update.
Pratichi?
I did not hear. The voice is cracking a bit. Can you just please repeat?
Two crisp messages to all the pediatricians who have been attending since last 2 months, 2 hours. Two crisp messages to end this CME. Only two messages which you want us to practice in our day-to-day.
So two messages you're trying to say after the end of the
Yeah,
whole
yeah,
thing.
yeah.
I think I would try to give one message per one talk. I think I would kind of give 5 messages.
Okay, no problem.
So one regarding medications is definitely trying to treat most fevers with paracetamol and not ibuprofen mefenamic acid. And if you need to give ibuprofen, it has to be like an emergency treatment in the sense if the fever does not come down despite paracetamol and despite cold sponging, then you can give a dose of ibuprofen or mefenamic acid. It has to be a drug which needs to be used but not used as often as we are doing. So that is the medication bit. For the hydronephrosis bit, insisting on a postnatal ultrasound. We would believe as pediatricians it's happening, but even in a metropolis like Mumbai, Despite antenatal findings, we have patients coming to us as 1 year and 2 year with severe UTIs and severe scarring whose postnatal ultrasound has not been done. So though we think it's, oh, of course it will be done, it is not being done as often as we think it is. So postnatal ultrasound is absolutely essential. Regarding blood pressure use, blood pressure, high hypertension, ABCs before the diagnosis. So management of the airway, breathing, circulation, stabilizing the blood pressure, and then simultaneously working on the etiology. A lot of times what happens, in academic institutes, we try to focus so much on the etiology and why is this happening. We don't really try to manage what is actually the problem, which is the hypertension and the issues it's causing. So treating the basics of hypertension before going towards etiology is very important. Enuresis, it's a motivational, it's a patient's game. No child is going to be better in one sitting or two settings. So motivation from our side as well as the parent side as well as the child side. And only if the child is at discomfort will the child cooperate. If the parents are just changing the child in the middle of the night, a child continues to sleep in the night, a child is not motivated, we are not going to get anywhere. And the last topic was, I think I missed something.
Nephrotic.
Syndrome.
Yeah. Clinical examination takes precedence over any other investigations. So any child with abdominal pain and nephrotic syndrome, please palpate. The first question I ask all my residents who come to say who tell me abdominal pain in a no-nephrotic, have you palpated the child? Peritonitis is an absolute clinical diagnosis. So please palpate every child who has nephrotic syndrome, because peritonitis is absolutely a cause of high mortality and morbidity. So these are my 5 last things to end this. Sorry,
Very useful tips. Thank you, Doctor. Dr. Pankaj. She has already covered.
Yeah. For nephrotic syndrome, whenever child presents with peritonitis, most of the time child is edematous, and in those kids do not rush for diuretic because they are in sepsis. And nephrotic whenever presents with sepsis, loose motions, fever, they are in actually intravascular depleted status. So do not rush for aggressive diuretic. Correct volume status, assess volume status, and then only think of diuretic, and probably we may need albumin for decreasing edema. Blood pressure monitoring is mandatory for every child above 3 years at least once in a year. Nowadays, we are seeing so many common problems, particularly after COVID. Maybe obesity and other factors are coming into play. Hypertension, even primary hypertension starting at very early age. So do monitor blood pressure every yearly. Now, antenatal hydronephrosis, probably I think still we need to, rather than educate or create awareness in our obstetric friends, the most common misconcept that parents or obstetrician tell our parents have been told by our obstetrician that if child passes urine, we don't need to worry. And this swelling or edema or hydronephrosis will resolve by itself. And as Pratishi has said, they are missed and they present very late, even requiring nephrectomy because of non-functional kidney. So probably it's time to educate them. I think rest all has been covered very well.
Yes. Thank you very much, all the speakers and experts and OBs of MAHAIP. Shall we call it a day? Let's end with a gratitude to all the speakers and experts.
Wonderful
Thank you very much.
presentations. All have presented wonderfully, and wonderful expert comments. Definitely, it will help everybody who have attended today's session.
Thank you, sir.
Thank you so much. Thank you so much.
Thank you. Good night.